My name is Kim Taubman. I'm a nuclear medicine physician at St Vincent's Hospital. So what we're talking about today is metabolic imaging of prostate cancer using PSR, prostate-specific receptor, also known as PSMA, with a PET CT scanner to detect these antigens or receptors on prostate cancer cells. The current standard for detecting prostate cancer is looking for an elevated blood PSA level, or prostate-specific antigen level, and doing a clinical examination and an MR and ultrasound, subsequently with a biopsy. Over time, these imaging techniques have been found to have significant gaps, and other techniques have been searched for to help diagnose prostate cancer. The initial diagnosis of prostate cancer using prostate-specific membrane antigen or PSR tracers has been found to be a very useful addition to the imaging armamentarium. PSR PET scans provide a valuable metabolic window into what's happening within the prostate, and reading the scans is relatively easy in that a scan will either be positive, negative or equivocal and can then be directly compared with the MRI. And part of the premise of the PETAL study has been to co-register to give additive information. The PETAL trial was designed to prospectively determine how PSR PET performs and how it performs in comparison with MRI in the diagnosis of prostate cancer, and also to determine how it actually performs when co-registered with the MRI and the additional information that this co-registered image provides. So certain clinical imaging problems exist. Firstly, because MRI is actually the initial test used for diagnosing prostate cancer, there can be a 10 to 30% false negative MRI result. And this can be a problem, particularly if the cancer is in a region where the MRI finds it difficult to locate the cancer, like at the prostate apex, or when the cancer resembles benign prostatic hypertrophy, because they can look very similar. The second problem is a positive MRI, which picks up a clinically irrelevant tumour, which then goes on to have major surgery, which could have been prevented. The third problem is a false negative PET CT study, where the tumour is in a region which is difficult for us to see on the PET CT, for example, very close to the bladder, or in the midline where the urethra is, and they can be misinterpreted for one or the other. And the fourth problem is a false positive PET, where there's actually inflammation or benign prostatic hypertrophy, which is misinterpreted. This is actually less common. So comparing the PSR PET and the MRI scans can actually help diminish the number of false positive and false negative findings. This enables more accurate diagnosis and biopsy targeting, because the actual cancer can be targeted for accurate biopsy rather than a systemic prostate biopsy, which is done today. About 10% of prostate cancers don't actually take up the PSR tracer, and this can be another area of false negative studies on our scans. However, these will most likely be picked up by the MRI scan, because often these cancers are more aggressive. In the PETAL study, as well as the blinded reporting of each of the modalities, the PSR PET by a nuclear medicine physician and a radiologist, we have a third independent reader who's trained in both modalities, who can report the co-registered PET-MR. Ultimately, each of the results is sent out to the referring doctor so that he or she can decide what to do with the patient clinically. When reporting scans for a clinical trial, it's important to have clear, concise guidelines prior to reporting for each of the modalities, and this is how we performed the reporting in this study. With PETAL, the PET and MR readers were blinded to each other's report, but the combined PET-MR reader was actually able to look at both the images for the co-registration. When reading a PET CT, in this study, we found that the indeterminate studies probably comprised around 15% of cases. This can be due to the low tracer uptake or the position of the abnormal tracer uptake, perhaps close to the bladder or urethra, which can be relative blind spots in PET reading. This is one of the times that the MR becomes extremely useful, because it can determine where in the prostate the cancer is, because PET is not so good at determining accurately the location within the prostate gland, and also the MR can determine whether the area of increased uptake is due to a urethral diverticulum, for example, or a tumour. In the same vein, in patients with a negative MRI but a positive PSR PET, the co-registration allows accurate diagnosis in a case which otherwise would have been dubbed negative. So the ultimate plan is to prove the utility of PSR PET in the diagnosis of prostate cancer, to validate co-registration of PSR PET and MRI in the diagnosis of prostate cancer, so that it can be used in settings other than teaching hospitals and university hospitals in the general community. And ultimately, patients may be able to come in and have a scan to exclude prostate cancer and save themselves from having a biopsy.